Hello, everyone. My name is Bernd Meibohm from the University of Tennessee Health Science Center, and we'll talk about the pharmacokinetics and pharmacodynamics of therapeutic proteins, now part 5. The goals of this section are to appreciate the ability of therapeutic proteins to trigger an immune reaction, to differentiate non-neutralizing, neutralizing, and cross-reactive anti-drug antibodies and the effect on PK and PD, to understand the effect of clearing versus sustaining anti-drug antibodies, to recognize anti-drug antibody interaction as a possible clearance pathway for therapeutic proteins. Immunogenicity is the capability of a substance to elicit an immune response. So most therapeutic proteins, as protein drugs, are immunogenic and may stimulate the patient's immune system to form so-called anti-drug antibodies, or ADA, that may inactivate the therapeutic effects of the protein drug. There are a variety of theories what triggers the formation of anti-drug antibodies, especially if the administered therapeutic protein is an endogenous molecule or some that is highly similar to an endogenous molecule. One of the dogmas that is used is that protein aggregates are immunogenic. So aggregates are being recognized as a main driver of an autoreactive response to human therapeutic proteins. Usually in the body, proteins are only available in monomeric form, and the idea is that if monomeric proteins are administered to a patient even after repeated administration, you would have immune tolerance to those molecules as they are recognized as an endogenous molecule, and by that would not have an immune reaction. However, once these monomeric proteins form an aggregate, then this aggregate may be recognized as a potential hazard for the body and may trigger a breaking of the immune tolerance and the formation of anti-drug antibodies. The ability of an antigen to induce an adaptive immune response can have a variety of different factors that are modulating. Of course, contaminants and impurities may play a role. As I mentioned, the aggregates and the formulation that ultimately determine the number and the availability of aggregates may play a role. The route of administration has been discussed as a potential factor. For some therapeutic proteins, there seem to be a higher incidence of ADA formation after subcutaneous compared to intravenous administration. Some thoughts about that are the potential of the formation of of aggregates after subcutaneous administration at the injection site that may ultimately trigger then this increased immune reactivity. There are also other factors that have been discussed, like the dose level, the length of therapy, genetic factors in individual patients, especially the HLA type has been discussed. And there are many limitations with regard to comparability of immunogenicity data based on the assay technologies that are used to assess anti-drug antibodies. If we talk about anti-drug antibodies, we have to differentiate between neutralizing and non-neutralizing anti-drug antibodies. Non-neutralizing ADA bind to the therapeutic protein, but do not interfere with its ability to bind to the target structure. So the therapeutic protein can still maintain its activity even though an ADA molecule is bound to it. In contrast to that, neutralizing anti-drug antibodies bind to or near the target binding domain of the therapeutic protein, and by that interfere with its ability to bind the target receptor. A specific form of neutralizing anti-drug antibodies are so-called cross-reactive anti-drug antibodies. Those are the ones that do not only bind to the biological therapeutic, so the therapeutic protein that has been administered, but also to its endogenous analog or homolog that corresponds to that therapeutic protein. An example for that, where this had fatal consequences, was a so-called EPREX case, where a erythropoietin medication was administered to patients. That erythropoietin was had a change in the production process, in the packaging material actually, that ultimately resulted in some patients to produce a condition called anti-erythropoietin antibody-mediated pure red cell aplasia. So basically, these patients formed cross-reactive anti-drug antibodies, not only against the erythropoietin that was in the EPREX medication, but also against the endogenous erythropoietin that was produced by those patients. And by that, they could not form red blood cells anymore. So cross-reactive ADA is very much a concern and is especially relevant for those therapeutic proteins that are replacing endogenous molecules like growth factors or enzymes in enzyme replacement therapy. What happens to the immune complexes that are formed when any drug antibodies bind to therapeutic proteins? So the body uses the same elimination processes as for any other immune complex that's formed. So they trigger the regular elimination process, which is uptake and lysosomal degradation by the reticular endothelial system. So phagocytic cells like monocytes and macrophages that ultimately recognize these immune complexes, take them up and degrade them to amino acids. That occurs primarily in liver and spleen, but is mediated by Fc gamma receptors, another Fc receptor that we have not yet talked about, an Fc gamma receptor that basically recognizes another binding site on the Fc domain of the anti-drug antibody, primarily Fc gamma R2. Human platelets contribute to the clearance of IgG-containing complexes as they also express this receptor and bind IgG complexes that and then are internalized, the platelet as well as the complex, in circulating phagocytes. So what are the potential effects of ADA formation with regard to pharmacokinetics and pharmacodynamics? So as we mentioned, you can have neutralizing ADA or non-neutralizing ADA, independent of whether they are neutralizing or non-neutralizing. They can have both an effect on the clearance of the therapeutic protein based on the fact whether the formed immune complex triggers the natural endogenous elimination process. If that process is triggered, then we have an increase in the clearance of the therapeutic protein, shown either here or here. And we have a so-called clearing anti-drug antibody, which results in reduced exposure and reduced activity. In some instances, we can have the opposite, that the immune complex actually stabilizes the therapeutic protein, and then we have a so-called sustaining anti-drug antibody. So let's first talk about the clearing anti-drug antibody. Those antibodies bind to the drug and alter its pharmacokinetics by increasing the clearance, reducing the systemic exposure, and decreasing the distribution to target organs. So the formed immune complex between the ADA and the therapeutic protein trigger the reticular endothelial system and ultimately constitute an additional elimination pathway, thereby reducing the elimination half-life of that compound. An example how this looks like is shown on the right side for a monoclonal antibody that has been given here in 4 weekly doses, indicated by the arrows on top, 4 different weekly doses. The red line shows what happens with regard to concentration time profile in individuals that have no ADA formation, so they are ADA negative. You see a nice build-up of the systemic exposure that results from these 4 doses of the antibody. In contrast to that, the same dose is given to individuals that now have the formation of any drug antibody. See that initially you get very similar exposure. Once the ADA formation kicks in after 1 to 2 weeks, you basically get a rapid reduction in systemic exposure, vastly increased clearance for this specific therapeutic protein. And by that, of course, you have reduced systemic exposure, and by that, likely lack or loss of efficacy of this treatment. The sustaining anti-drug antibody, as I mentioned before, also forms immune complexes, but those complexes, based on their size, their shape, their charge, do not trigger regular endogenous elimination process, but serve as a storage depot for the therapeutic protein. By that, reduce the clearance of the drug and result in a prolonged systemic exposure and increased distribution to target organs. The half-life of the therapeutic protein often approaches, in those cases, the half-life of the ADA, so the immune globulin leak. This is often observed for small protein therapeutics like cytokines or hormones, where the immune complex formation then stabilizes the molecule, and by that extends its half-life. It's possibly also mediated through FcRn-mediated recycling, because now you have the ADA molecule that can serve as the driver for this recycling process with an intact Fc fragment. So ADA is ultimately an additional clearance pathway for therapeutic proteins. That's shown again here with our 2-compartment model, typical for the 2-compartment pharmacokinetic model for a therapeutic protein, where you can have, as we discussed, pre-systemic degradation. We have proteolytic degradation for those molecules that are small enough. You can have that can undergo glomerular filtration. They may undergo renal metabolism. We talked about FcRn recycling and about target-mediated drug disposition as a potential elimination pathway. And now, in addition to that, we have the anti-drug antibody formation, the immune complex formation, and ultimate removal and degradation of this ADA drug complex as an additional clearance pathway that needs to be considered for therapeutic proteins. So in summary, for this section, therapeutic proteins may elicit an immune response in individual patients that may lead to the formation of anti-drug antibodies. Numerous factors play a role in this process, including aggregates of the therapeutic protein. ADA may be neutralizing or non-neutralizing, independent of their neutralization status. They may also have a clearing or sustaining effect on the PK of the therapeutic protein. Clearing ADA effects are a frequent cause of therapeutic failure in long-term therapy with therapeutic proteins. Again, now a self-assessment question that summarizes some of the concepts in this section. For those interested in further reading, there is a list of textbooks and publications that might be of interest for you that highlight and summarize some of these concepts again in a bit more detail. Thank you for your attendance.